Daniel, before I pester you with some more questions, and then we are going to have another guest join us in a couple minutes as well. So here's a question from Richard: doesn't radio, IgG, etc., have similar talks to ADC? And so I guess that it's kind of like this: the radio talks versus the drug mediated talks. What's your take on kind of like the de-risking radiopharmaceuticals?
So first of all, we don't have an FC. We have only the FAB, fragment. So we don't have the toxicity of the full antibody. Second, Astatine-211 is the safest of all radioisotope currently available, and I'm sure we'll talk more about its unique properties.
Yes. So I guess maybe if we jump into that right there, right? Another concern that was brought up in the chat with regards to radiopharmaceuticals is like, is there an administration barrier because you need a specialized facility for disposal and storage? But I guess maybe if we get into Astatine-211 itself, what makes this so much different from other radioisotopes that have been used in the past?
So yes, it's very interesting because the title of the podcast is the fact that it's the rarest element, and supply has been a big issue for radiopharmaceuticals, including for lutetium and even more now for actinium. The reality is that astatine per se is rare, but you make astatine from bismuth, and bismuth is extremely abundant and extremely cheap. So the way you make astatine is that you take a bismuth target to a cyclotron, you bombard with alpha particles, and out of the cyclotron comes the astatine powder on the target. And then obviously, you have to purify, conjugate, and get to a drug product. But there's unlimited supply of astatine because of the unlimited, at least as a raw material, as opposed to the other, radionuclide.
Interesting. Okay, so this is it's much. Would it be fair to say then it's much less cost prohibitive compared to other radioisotopes in the past?
Yes, because obviously it's supply and demand. So if you have enough astatine available, it's going to be less expensive. But the other very unique properties, it's an alpha emitter. So alpha emitters, true also of actinium and lead, have a short range, which is much easier to use than the beta emitters. It also has a short half-life, 7.2 hours. So 7.2 hours, the half-life, you say, but that's a problem in terms of supply. Are you going to need to have a cyclotron next to every patient? But let's look at the clinical benefits. If you have a 7.2 hours half-life, it means that essentially the radiopharmaceutical is gone from the patient body. And some of the challenges that you have with other radioisotope, such as bone marrow depletion or kidney toxicity, are much less likely to happen.
What does the decay chain look like for?
So it's also, that's another advantage. It's a very simple decay chain, and as a result, the waste management is also much simpler. And to the question of what do you need to do? I mean, you need to keep the patient in the hospitals, which sometimes you do with actinium because you want to monitor the side effects, and also you're concerned about the radioactivity. Here, essentially, the assumption is that this could be administered on an outpatient basis. So it could be done in an infusion center. It can be in an academic center, but it can be also in a community infusion center. In terms of preparation of the therapeutic dose, you have some protections, but you don't need to be in a bunker. So Again, that simplifies the supply chain.
Excellent.
Yeah, and it wouldn't be anything more like dangerous than any other radiopharmaceutical, right?
No, less.
Yeah,
Because
yeah.
Because it breaks down so quickly.
Now, one more quick thing to the decay chain, because one of the advantages of alpha particles is that they're extremely powerful, right?
Yes.
They have a short range. They're very powerful. Beta emitters can be a little bit more messy because they have a wider, cloud of influence.
Yeah.
Right. But the other problem is that they tend to eject themselves from the chelator.
Mm-hmm.
And if you have if the half-life of astatine is 8 hours, but the half-life of a daughter isotope is 30 days,
Yes.
and you have the astatine decays, it pops off the chelator, and then you have this radioisotope that decays over the course of 30 days in someone's kidney or their bone marrow. It's a problem. So is it a single decay and then it goes to
It's a single decay. So that's the difference with actinium. So you don't have to worry about the daughters. And remember, actinium is 10 days half-life.
Yeah.
So you have to be careful for a long time.
Yeah. And those things pop off. So I heard one time that it's pretty much guaranteed that the first decay is going to release it from the chelator. I don't know if it's 100%, but it's obviously pretty high. So it can be dangerous. So
also, you're talking about chelators. You don't need chelator chemistry with astatine, and all you need is a covalent bounding. So it's much more seamless to conjugate.
Okay, so forgive my ignorance, but is that relatively uncommon to have I know that like iodide is a covalent, but all the metals normally require chelators.
Yeah, so it's similar to iodine and fluoride that you can have a covalent linker.
Interesting. Okay, so then there's no issue with detachment then, right?
No.
Right. Cool. There you go.
Awesome. Okay. Well, one last question before we bring in another guest from the organization. So I guess from this unique, from this kind of unique undertaking, how would you say it most differs from other solutions out there? So we think of radioisotopes in the past. I know we might be retreading a little bit of ground here, but what really makes this approach different from everything that's come before it?
I think it's really democratizing radiopharmaceuticals and giving access to the power of radiopharmaceuticals to millions of patients. Because, if it is more cost effective to produce, if it's available on an outpatient basis and it's safe, we didn't talk about it, but there's a question is a single dose sufficient, or do you need to have repeat dose? If you have 10 days or even more with lutetium, half-life, you want to make sure that there's no accumulation.
Gotcha. And so again, with something like this, given that the half-life of Astatine-211 is so short, you don't have that problem of previous doses accumulating on top of the existing.
Exactly. I'm not saying that it's going to be daily treatment,
right?
But even if it's once a month, obviously it's gone a long time.
If it's outpatient, even if it was like twice a week, it wouldn't be an issue.
Exactly.
Just go to your local infusion center and you're good to go.
But remember, what I said from a clinical standpoint, the power of the alpha emitters is that you can take care of isolated cells. So you can take care of micrometastasis that you don't necessarily see, and you can take care of residual disease, which is, one of the reasons why patients relapse. And, patients relapse in HCC, they relapse in myeloma. That in myeloma, there's a new FDA guidelines that minimal residual disease can be a registration, endpoint. So there's a relationship between MRD and survival.
Okay.
So tackling minimal residual disease in different types of cancer is really paramount. And there's not too many solutions. It's not going to come from checkpoint inhibitors. It's not going to come from chemotherapy.
immunotherapy at all, really,
No.
other than some kind of cell therapy, which you wouldn't be able to do in MRD patients because it's like post-treatment.
Yes.
So yeah, I guess having that nice, like relatively safe, convenient option that you can give patients right after some kind of really intense treatment protocol is really nice.
Yeah, and in HCC, half of the patients goes through some kind of surgery and half of the patients goes through therapeutics.
Mm-hmm.
Now, the radiopharmaceutical approach is relevant also to the surgery patients, either prior to surgery or post the surgery, because you want to make sure that you get rid of the unwanted cells.
Sure. Yep.
Very good. All right. We have had a